Good morning, everyone. I'm delighted to be here. I'm stepping in to chair this session because the person who was to do it wasn't able to attend. My name is Rachel Ballard, and I am currently at the Office of Disease Prevention at the NIH. So we have a very terrific set of presentations by really lights in the field. Tim Lobstein from the World Obesity Federation, Shariki Komuniki from the African American Collaborative on Obesity Research Network, and then Nicola Dawkins-Lynn from ICF International is also presenting. This is an NCORE session, the National Collaboration on Childhood Obesity Research. I assume many of you may have heard of it. It was first officially launched in the first year of President Obama's administration in 2009, and we have, I think, 4 or 5 sessions that are to highlight work that NCORE is helping to move forward. This is one of those sessions. There's also one at 1:45 today looking at what we're learning about sugar-sweetened beverage taxation evaluation. There's a breakfast roundtable, so if this was not early enough for you, we have a session at 7:15 tomorrow morning, and that's going to be really about lessons learned from international global obesity prevention. And there is a Connect and Explore event on looking at cyclovia and open streets. That's at 8:15 tomorrow morning. And then one on Saturday, the Healthy Communities Study, which is supported by NIH, but was first started from early conversations with the NCORE probably back in about 2008, 2009. I also neglected to mention that we have a terrific discussant from RWJF, Karabi, and I'm not Acharya. I'm here just to stand in as the chair and moderator and make sure that the slides move forward. But I wanted to make just a couple of points. I am now at the Office of Disease Prevention. In that office, we have something called Pathways to Prevention workshops, which really replace efforts in the past to do consensus development conferences out of that office. But they're really intended to identify research gaps. We had one yesterday on really understanding what are the data systems and resources we need to really understand what's happening in suicide prevention in the United States and what's working and not working. And I want to make people aware that we are now planning with the Obesity Research Task Force at NIH a similar kind of methods-focused workshop on what kind of designs, resources, et cetera, are needed to do evaluation of natural experiments in obesity prevention. And that workshop is being planned for the fall of 2017. So I hope we'll make sure that that is widely announced, and it is an open workshop, so I hope people will participate in that. I think increasingly we're understanding as we need to look across multiple levels to not understand just individual, but also environment and contextual factors that influence whether people are successful at maintaining healthy behaviors, that our data resources at the local, state, and national level are really critical for that type of research. So we look forward to getting input from people on that. But let's move now to Tim Lobstein from the World Obesity Federation. He's coming to us remotely. And Tim, I'm going to be moving your slides. So, oh, I'm sorry, Shriki's first. So I didn't have, so my apologies. Shriki, you're first then.
It's not too late for me over there, so. Good morning, and thanks for coming. I see some familiar faces. This presentation, let me just get oriented here to the clicker.
Here's your clicker,
okay.
And there's the arrow.
Okay. This presentation, I think from my perspective, is meant to change the way of thinking about measuring success in addressing the epidemic. We use national data, which are good for affecting national policy. Most of the data are not presented at a sufficient level of refinement in terms of subgroups to see what's actually happening in different groups. So that's what I'm going to talk about, actually, kind of disparities, not just in the problem, but disparities in the solution. So the ethnic minority and low socioeconomic status populations have higher prevalence of obesity in general, and I'm going to focus on data for children, and apparently fewer of the high-impact solutions, because the trends are not as favorable in terms of what's been happening with success. And so then I'll talk about the clues to the solutions. What are we doing now, and what do we need to do differently? So first, on the problem, I'm going to show you 4 slides. They have the same color scheme, I hope, and will make the point of how different the trends are. They're different in different age groups and by gender. So in this first, you can see that the white children, 2 to 5, and this is not gender specific because there's not enough numbers to see clearly what's going on in the race by gender groups. But you can see that the white children are showing a decline at the bottom of the, this is the pointer, yeah. The white children are showing a decline. The Mexican American children are highest and seem to be leveling off, and the black children in the blue line are actually increasing in the prevalence of obesity. That's the 2 to 5 year age range. So now I'm going to show you boys and girls in the 6 to 11 year age range, again to illustrate the differences in trends. Maybe the most striking thing is that the Mexican American boys are the highest. They appear to be leveling off there, but the black boys have increased tremendously to be about equal to where the Mexican American boys are, and the white boys are decreasing. So success in the white boys, but a widening of gaps and a worsening, especially in the black boys. And in the girls in this age range, the school-age children, you see a leveling off in the white girls at the bottom in the purple. You see Mexican-American girls going up and black girls appearing to stabilize. So much of the data you'll see is 2 to 19. And that doesn't tell you much at all about what's going on, because these are cross-sectional data, and the different ways of children coming in are actually experiencing the environment and the risk factors for obesity differently. This is all race and ethnic groups by socioeconomic status. At the bottom of the slide, you can see what's going on in the children in families with incomes 400% or more above the federal poverty line. At the top, you see the increasing trend in children and families living below the poverty line. So these are data for all groups. There's analysis of Haynes data in adolescence that shows that the poverty issue may be the greatest in the white children in terms of unequal receipt of the solution or unequal progress. So now I want to spend the rest of the time talking about solutions, and these will be brief presentations, and we can hopefully have a good time for Q&A. First, to continue on the socioeconomic status trend, it will not be that we can have solutions, broad solutions, even by SES group, or even by gender, or even by race ethnicity. We're going to have to tailor solutions at the level of the subgroups. And then I'll talk about the disparities in the context and the need for new theories of change. So this is from a MMWR report, and it just shows the trends by education of the head of household in white and black boys and girls in the 2 to 17 year age range. And what you can see here is that the lines are going all over the place. The solid line is the highest education of the head of household, college educated head of household. So it's often, especially in the white children, it's the lowest prevalence of obesity, but it's going down in the girls at the bottom of the slide. Okay. It's going down. You don't see it going down in boys. So within the whites, there's a difference in the highest group. And then this is the least educated group, shooting up in the girls, not so dramatic in the boys, not a significant trend. In the black children, This is the highest educated group. It's the lowest, but it's not declining. And there's no association at all up here in the girls. So these are in the boys, these are the girls. So how the solutions that affect different socio-demographic groups are being experienced is really different. So this is the map of the solutions that we're using for tackling obesity in general and childhood obesity in the U.S. This is from the Institute of Medicine, or now National Academy of Medicine's report called Accelerating Progress in Preventing Obesity. And I think that many of you have seen this before. There are 5 domains of activity. There's a focus on place, the settings related to food, physical activity, schools, healthcare, work environments of, say, parents, and surrounding that, the message environment. So physical or virtual spaces where we can make change. And the potential goals, this is my wording, not the wording specifically from the report, but the things we would do in these environments are shown here. We can change the products, we can change affordability, promotion in certain settings, we can change the advice and options in the healthcare setting, routine physical activity opportunities, maximize the opportunities for schools, and change the messages, strengthen the public health messages, and weaken the commercial messages in frequency and impact. So that's the way we've been looking at things in terms of the settings. Part of this is because there's an implicit nudge theory behind this, that if we can really change these settings, the behaviors are going to follow along, and that's a lot of what we've been looking at. Within the report, there's also clarity that the settings are not equally distributed or experienced by people in different groups, and so the starting point for change, the opportunities within those settings for change, and the responses of the population to change are different in different groups. So to achieve equity, we have to consider any interventions with this in mind, and we should also report, thinking about Rachel's saying, what are the measures, we should also report much more routinely the subgroup differences rather than just the general differences, because the general differences create an aura that we're making progress when in fact some groups are going in the opposite direction. So the next 3 slides are just some of the reasons, possible reasons why, the clues to solutions. This is kind of intuitive, looking at physical environment, food environments, physical activity environments. Focus, for example, on the economic environment, costs of healthier foods, deals and price promotions for unhealthy foods, funds available for the school meals, where are these kids going to school. Fast food and soft drink companies are a key part of the economy in a lot of communities, especially ethnic minority communities. And so when you think about the economic environment, you think about where people's loyalties are in terms of where they're getting sponsorship and scholarships and so forth. And the other factors here in physical and message environments you're familiar with. I will just point out this target marketing issue, which is a chronic issue for Black and Latino children of high media exposure and targeted, tailored marketing to them. For physical activity contexts, again, there are economic factors, which we may not touch enough. There are a lot of physical environment factors potentially, depending on where children live. And the message environments, question marks, because we haven't studied the message environments about physical activity anywhere near as much marketing and so forth as we have about food. And social cultural context, which is where some people go first, thinking, okay, well, these are minority ethnic groups, they're cultural, it's their behavior, it's their habits. There are definitely behavioral and attitudinal factors, and some of the ones that come up a lot in the literature are cuisine and body image norms and so forth. So they're in the mix as well to be thought about. And then the attitudes about physical activity, which again are probably not studied as much as the ones related to body image and food. But these are all things to measure and to keep in mind. So how do you put this all together? I'd like to pose the question, what are we actually trying to do in the settings? Have we thought through the process and the theories of change, or are we really relying on a sort of a magical effect of changing the environment, and people's responses are just going to follow along. We have been reluctant in the early stages of this to talk too much about individuals because that's where everybody was already stuck, blaming individuals for their behaviors. But now I think we really need theories of change that always incorporate people and place. And the people part is where you can bring in the factors related to groups. So I am working on this sort of new framework of the processes we're looking at are increasing access, increasing resources, receptivity, or decreasing deterrence. And this is where I've come with it, making another Venn diagram that's based on these 4 processes, and then trying to place our interventions as to which of these processes they're driving, with the idea that in order to have a comprehensive, sustainable impact, we need to be at some intersection here. And what I find is that even though we are doing a lot of things to improve access and the potential for effectiveness, we haven't worked in the receptivity as much. There are some good programs combining the educational and the environmental, but perhaps not enough. We are working on reducing deterrence, but here's the area where I think we need to face reality and add in the social determinants. There's no way that we can actually address the factors that I just went through briefly on those other slides without looking at the underlying social context. And I don't think we've thought through how to do it until this point. The RWJF Culture of Health framework is really pointing in this direction, but I don't know if everybody understands why our work in the obesity field has to be in a framework where social determinants of health and housing and transportation are really a part of the mix, not just something that you do if you're interested in policy, because all the treatment interventions and prevention and individual interventions or the setting-based interventions are going to be affected by these things. So we need to look at programs, how we can incorporate programs with the educational programs, especially the ones targeted to high-risk groups, economic. We have to integrate the anti-hunger initiatives with the obesity initiatives, subsidy programs, and targeted federal programs. And so this is probably in a local place, because national policies, there are some targeted national policies, but putting these things together has to be in a place. So the implications of this, I think, are that when we're addressing disparities, we have to find solutions, not just be able to really tell you that the prevalence is different, but we have to tell you that the solution is different and how it's different and what is needed for sustainability, effectiveness, and sustainability. The theories of change have to be people-place theories of change, and they have to be comprehensive and not just thinking that, fixing the school lunch will do it alone or one thing alone, and not thinking that just doing something in school will work when out in the community there are a lot of deterrents and opportunities that have not been incorporated. So finally, the take home, if you diagnose the environment in which this is taking place, I think the reasons for the disparities in solutions are clear. We have to address on a community-specific basis the social determinants as a part of the mix. Thank you. Are we doing questions now, or?
I think, why don't we plan for a few questions?
Okay.
People have them. I think that's okay.
Or comments, right?
Right.
Tracy. Hi.
Yeah, this is a really exciting framework, Shariki. And do you have this, is this accessible in a report format, or I'm taking notes on your slides, drawing the diagrams and so forth?
Yeah. I appreciate your interest. I've been working on this. I first thought about it in conjunction with the Roundtable on Obesity Solutions, where we were looking across the groups and looking at what was missing. And I haven't published it because it's really a thought process of understanding what the theoretical perspectives are in other fields that we can bring to it. City planning, for example, is one that I've been quite fascinated with, that city planners by definition, have been looking at the people-place tension for a long time. So I'm trying to learn a little bit more before I write it up. That's the answer. But, you know, it's on the slides, and with proper attribution, you can, you know, use it or circulate it as you see fit.
I have a rather specific question. In regards to the physical activity pieces that you were touched on a few slides back, you noted attitudes about rest.
Right.
I was just wondering if you could elaborate a little bit on what you mean by that.
Yeah, sure. That specific finding has come from some work that I did with colleagues a long time ago. It's in the literary works and can be uncovered if you do qualitative work with populations for whom labor is considered to be stressful, and resting and achieving balance and recharging is in the ethos. So sometimes people think, well, after a hard day's work, why would I put on spandex and go running around the block? That's going to raise my blood pressure. It's also in a couple of national surveys, this idea that exercise is not good for you in terms of raising your your risk as opposed to calming it down. And so it's a mixed message that's underneath in some of the cultural attitudes. Yeah. Okay, maybe we should hear from Tim, right?
Yes.
Okay.
So our next presenter is Tim Lobstein, and we're just going to get those slides going now. And he is going to be addressing tackling inequalities, rethinking the intervention design. While we're waiting for that, I'll just, oh, he's on, great.
Hello, Tim.
The person whom you're trying to reach is currently unavailable. Please leave a message after the beep.
Hello, Tim.
Ah, yes, you have me now. Sorry about that. I don't know what happened. Don't think it was my end.
We're ready for you then.
Oh, okay, good. Can someone turn the laptop so I can see the screen? Because I'm looking at the audience at the moment, which is very nice, but I'd like to know what slides I'm showing. So can someone turn this laptop around? Thank you.
Is that?
Yep, that's good. And is there someone there who can say, who can move the slide forward when I ask?
Yes.
Great.
I will
Oh,
move
well.
those for you. Rachel Ballard will move those for you.
Rachel, thank you. Okay, I'm very sorry about that, but I'm very delighted to be able to address you this morning, afternoon for me, morning for you, and to save myself the journey of 6,000 miles round trip to give this talk. So bear with me that I'm only a voice, and we don't seem to be able to get a live video stream. My name's Tim Lobstein. I work at the World Obesity Federation, and that's an international body with about 50 regional associations and national associations as our membership, which in turn have about 30,000 clinicians and researchers in national associations. My own role is particularly to promote policy issues and work on policy issues at international level. And today, I just wanted to say a few words that will complement the talk that Shariki has just given, I hope, but give a little bit of a sort of international and European flavor to it. So, next. Thank you. I'll just say a few words about global trends internationally and the rapid rise both in high and low-income nations. So a little about European examples of disparities in child obesity. talk about the policy issues and the research needs next. Okay, internationally, there's the USA running along the top, although in fact now several countries, particularly in the Middle East and in the Pacific Islands, now exceed the child obesity as well as the adult obesity rates for the USA. But the most important thing I want to bring out from this slide is the way that over the last 2 decades, low-income countries have been rapidly catching up, more rapidly than the USA showed back in the 80s and 90s. So Mexico particularly, but Brazil, Saudi Arabia, South Africa, and even China running along, that's the lowest line there, but it's been increasing significantly from about 4 or 5% 20 years ago, 25 years ago, to over 15% child obesity. This is school-age children, not under fives. There's a lot of work done on under fives, but I'm focusing here on school-age children. Next. Okay, there's some very useful European work. One of the problems with the previous slide is that all the surveys that are done tend to be done by different people at different times and don't necessarily really use the same survey samples or techniques. And so the comparison point to point isn't always ideal. Here is a survey run in the European Union in 7 different countries using exactly the same techniques, same age range, same sampling methods, and same criteria for what defines child obesity. And here you see extraordinary variation between countries in the levels of overweight, from 40% or more in Greece down to fewer than 10% in the Netherlands and 14% odd in Norway. So you can see there's a huge range within the countries of the European Union. Next slide, because you will see with that one that the previous slide we had high education families, which if you like are the optimum level for likely to produce healthy children. If you add in now the low-income families, or lower educated families I should say, families where the parents haven't attained a reasonable level of education, in virtually all those countries you see an increase in the risk of obesity for the children in those families. With the exception of Greece, which is at a very high level for both high-income and low-income, low-education families, high education, low education. So the lessons to be drawn on these samples of European children are that there is a social gradient for children in most EU member states, at least by parental education, that slope of the gradient is actually quite different between different countries. So it's very steep in Slovenia, the second from right, but actually quite flat in Greece, possibly because everyone is poor or possibly because it's such a high level. But fairly flat also in Norway. There's very little difference really between the higher educated and lower educated. And that raises interesting questions about social policy that might be explaining that, because in Norway there is a very high level of welfare support for lower income families, indicating, if you like, that the gradient of social income is actually very flat in Norway. And the overall level of obesity is actually quite low. So there's an interesting relationship to be explored between the nature of the welfare state, the disparities in income and education level between higher and lower groups in the society, and the risk of ill health, particularly obesity in this case, to be done. So that's another bit of exploration to be done. But the point I want to make here is that there is high variation between countries, and there is a slope which in nearly all cases goes from low risk for the higher educated families to higher risk of obesity in children in lower educated families. Next. Now, this is perhaps the most perfect data I've ever come across. It's for England, which wasn't included in the previous slide. It's for England, and it isn't a sample survey. These are all children, or 98% of them. In the red columns, or dark red, are age 5 to 6, which is actually school entry period for younger children. They go to school at around age 5 to 6. That's when they have to start school. And age 10 and 11, which is when they transfer from junior school to senior school. So that's entry and exit from junior school, basically. And what's the take-home message here? Well, firstly, that the slope of the gradient is absolutely consistent This is a measure, this is an interesting measure. It's not education alone, it's not, it's not income, family income alone, but it includes both of those, plus measures of area deprivation. That's to say sort of housing quality, access to facilities. So it's a neighborhood as well as a household index of, if you like, social deprivation. Multiple deprivation, it's called there. And it shows this extraordinary uniform gradient from low risk of obesity in the least deprived families through to a high risk of obesity in the most deprived families. Very smooth gradient, absolutely consistent, lovely. And that's been repeated, that survey, over the last 5 years. And in each case, we're getting these very smooth surveys, very smooth gradients. Second take-home message is that the gradient has increased as children get older. So the younger children, it's got about 6% up to 12%. In the older children, it's more like 12% up to 24 something percent obesity level. So that is an increase in the slope of the gradient as children get older, or to put it another way, as they are exposed to this deprived environment over time. So worth remembering, particularly for this smoothness of the gradient, if you're using a sort of deprivation index like this. Next. Okay, responses, policy responses. We've had two major ones in the last couple of years. The first is the EU Action Plan on Child Obesity. And next, please. The World Health Organization Regional Food and Nutrition Action Plan. Now, what's the difference between the EU and the WHO European region? The EU is 28 countries, mostly Western and Central Europe, as you would know it. The WHO region then includes all those countries, plus Turkey, Israel, and the whole of the former Soviet Union. So it actually stretches all the way to Vladivostok on the facing Japan. So it's a huge region, but it covers all of the EU as well. Now, I've put both these documents up because they take a slightly different view when it comes to discussing disparities or inequalities in health risk. So next. Okay, so the one on the left, the European Union, where it mentions social disparities, it talks about individuals of lower socioeconomic status identified in the strategy as a priority target for action. Okay, that's one approach, but let's compare it with what the WHO says next. Okay, that says that they want to achieve a universal access to affordable, balanced, healthy foods, equity, gender equality in nutrition for all citizens. Next. And again, they repeat themselves really, achieving universal access to good nutrition across the social gradients. Now, you'll see there is a slight difference in the nuance there, and I think that's what we need to explore a little more here, about targeting and about the social gradient as a whole. Next. Okay, if we remember this beautiful example of a social gradient, we can sort of stylize it graphically and discuss how we could change that gradient. How can we improve it so that social disparities aren't as strong as they're pictured here? Next. Okay, so some population approaches may increase the gradient. Next. Okay, there's your gradient. And if you, next. That's right. If you do something like, let's say, some social marketing adverts on public broadcasting to say you should all be eating healthier diets, some people will pick up those ads, some people might listen to them, but it tends to be the better educated, those with the resources to understand and implement the suggested changes. You might say the same for gym membership. If there's an offer of access to a gym, well, the people who pick that up will be people who have spare time to do that, who are motivated to do it. That tends to be the people who are less deprived. More deprived families have other problems to deal with and are less likely to pick up on these sort of, if you like, social marketing or opportunistic initiatives. Next. Okay. Now, if you went down the road of the European Union document, which is about targeting, you might get something like this, where you decrease the obesity risk in a highly targeted group, the most deprived in this case, which, okay, I mean, that's something, and at least the gradient has improved a bit, because in the previous example, if anything, the gradient increased by by the strategy. Here, you might have improved it a bit, but you haven't really solved the main problem of a social gradient, of the disparities across the whole spectrum. So, next. Okay, now, if you do a sort of pure universal approach where everyone is exposed to a similar intervention and all of them respond similarly, then you would get an improvement in obesity levels, yes, but it wouldn't really change the social gradient. You haven't necessarily improved it more for one group than another, so the gradient would stay the same. Next. Okay, so what we're looking for, come to grand finale, what we're looking for is a universal proportionality, which is, it applies universally, but it is proportionally applied to those who need it most. So it benefits everybody with additional benefits to those who need it, who are at greatest risk. So that's what we're really looking for. So now, can we think of interventions that might achieve this? And there I'm really stuck. I've come up with some suggested checklist next, which might help us to predict in advance or to analyze whether interventions are likely to achieve the sorts of effect we want, to improve everybody's health, but to improve it particularly for those who need it most. So we can talk about the underlying exposure, we can talk about how the intervention might reach everybody, the nature of the intervention and how people will respond to that, whether they take it up and how well they respond, and how long that response lasts, how it's sustained, and what might push back against it over time. So we can dream up a checklist, and this is really off the top of my head. There's nothing I've found that has helped me to come up with a list like this, and I think I would love to see someone do so.
I think it may not be connected anymore. The vagaries of DC connectedness. Huh? It is.
Okay, I'm here. Oh, hooray! Hooray! Okay, we're back in. Now, where did you get to?
We didn't keep giving your talk, so you can get.
Well, you could have. Shariki's seen it twice already, so you could have done it with. Okay, thank you everyone for your patience. I know I've only got a few more minutes. I haven't really got any minutes left, so I'll just quickly sum up here. There's a checklist of some possibilities. If you have a sort of thought experiment of trying it out on a couple of interventions, if we think about TV advertising for junk food, yes, exposure to the ads is greatest for lower socioeconomic groups. The reach of the intervention, if you banned junk food advertising, should be to everybody, particularly for those who are lower socioeconomic. The take-up is presumably for everybody because they're all exposed to a ban. So that would have a proportional universal effect. So that's sort of thing we might think would work on an a priori basis, but we don't know that. Next. Okay, if you think of something like a 3-month school intervention to teach healthy eating, yes, you might reach lower socioeconomic groups. It might have a good impact across the groups there, the reach, the take-up, and the response. But the take-home transfer, not sure how well that would work. Might be higher in higher economic groups, the enthusiasm of the parents, and it'll be challenged by family habits and so on. So it's not clear that that would have the sort of universal proportional effect that we would be looking for, and it might indeed increase the gradient. But I don't know that. Next. So someone's got to tell me. So this is where I appeal to all of you in the room. If you're able to do this sort of research or want to collaborate on doing this research, I will be delighted, because this is where we need some good work done. What works and what increases the gradient, and what do we think can we develop some tools for assessing, particularly in advance, whether something would increase the gradient or not. And I think at this point I'm going to say thank you to everybody, and I shall remain online listening and come back for the questions at the end. Next.
Great. Does anyone have any questions?
Okay, well, that's good.
Sorry, I interrupted people's applause, so let's do that. There is one question, so.
Hi Tim, this is Shuan Nung at the University of North Carolina at Chapel Hill, and I guess I have a question, and you alluded to this in your comment about identifying the potential policy options and knowing and figuring out which of those affects certain populations or subpopulations more effectively as opposed to other subpopulations, and how it might vary from country to country as well, and the need really for the evidence base in order to actually come up with a checklist that is subpopulation and context specific. I think it's pretty important. Yeah, I'd love to hear your thoughts on this as well.
I'm really sorry, but I didn't hear most of that question. Could Rachel summarize what I need to know?
Can you hear me now? I'm not sure.
I don't think that's what you want to just come. I think the main thing was sort of this idea of thinking about the social context and the specificity at which one needs to apply interventions depending on the population, the social context, the environmental characteristics of that particular group.
Yeah, well, I fully agree, and I think that was the point of Shariki's sort of overlapping circles too, that we have to try and work out, what are the influences, how can we best characterize them, and can we, before we spend too much money on interventions that don't work or make things worse, can we find the tools that would help us assess these factors in advance?
Yes, Shariki? I think probably just walking towards this mic would be good.
Oops. Hi, Tim. This is Shariki asking a question you've heard me ask before. The race-ethnic disparities in the UK, I came across a paper by Zinalawala, some people at at University College London, that looked at a lot of different ethnic groups in the Millennium Cohort Study and ECLS, and they're saying that SES explains a lot of the disparities in several groups, and then there are other ones where cultural and family factors seem to have more of the explanation. And so I wondered if you could comment on what is the state of research in the UK or globally on this intersection of race, ethnicity, immigrant status, and with the socioeconomic status.
Yes, certainly risk factors are unequally distributed, and as you say, there'll be some racial groups who are at higher risk of obesity developing in childhood, and some with lower, and it's very hard to tease them out. I don't know of good studies that have looked at interventions differentially according to different racial groups, and so the short answer is don't know. Slightly longer answer is that there are studies that have looked at interventions in younger children, preschool children, according to whether families are sort of recent immigrants or are well enculturated. And that has sort of shown that you do need different tactics for recent immigrants because they're bringing their own cultural backgrounds with them in their first generation. So there are a few studies like that, but it is a really underexplored area. And we've in Europe we've got this huge increase in the numbers of people who are coming into Europe from the Middle East, and that's going to bring a whole new range of interesting issues in. Okay, they tend to be slightly better off because they could afford all the bribery to get to Europe, but they are also bringing with them cultures that are, some of them had quite good nutritional cultures and child feeding practices, but they've all been highly disrupted, of course, by the circumstances in which they're now finding themselves. So the whole thing is it's a glorious example for some research for somebody, but it's also a nightmare for some of the people involved. So there are issues there. I appreciate the question you're asking. I don't have a simple answer that says, yes, we've got beautiful data about how racial differences respond to different types of intervention. Don't have that.
Great, thank you, Tim. Our next speaker is Nicola Dawkins-Lynn, and she is from ICF International and is going to present the results of the Childhood Obesity Decline Study, an effort within INCORE.
Thank you very much, Rachel. I'll stand back a little.
Sensitive.
Okay. Well, while my slides are being loaded, I'll just welcome everyone. Thanks for joining the presentation this morning. To advance forward. Okay. I'm going to be sharing a presentation, as Rachel said, on the Childhood Obesity Decline Study. And it just turns out that this study presents a couple of nice case examples of some of the issues that Shariki and Tim were describing. First, I'll note this is a study of the National Collaborative on Childhood Obesity Research. My organization, ICF, directed the work with a grant provided by the Robert Wood Johnson Foundation, and RWJF is one of the 4 member organizations you see listed here, and representatives from each of these organizations helped participate in guiding this work. So, this work really began when members of NCORE were noting the signs of progress occurring around the country, various places where the rates of childhood obesity were starting to decline. And they wondered, what might we be able to learn from these different places? So one of the main focuses of this work really was in exploring the factors that might have contributed to those declines. To address that, the broad research questions that we sought to answer were things like what initiatives, strategies, and practices occurred in those sites, and what about contextual factors? What role might those have played in facilitating or inhibiting progress, and what could we learn about similarities and differences across the sites? And then also, what kinds of changes were observed in subpopulations? So that could be age groups, or it could also be groups with a higher burden of childhood obesity. We were really particularly interested in understanding whether and how any of the sites were able to reduce disparities in rates of childhood obesity. So we began this work with a careful site selection process. We applied specific inclusion and exclusion criteria that you see here. I'll just highlight a few, but in the beginning, a search of the literature and kind of popular media identified about 19 different communities where declines were occurring in rates of childhood obesity. We applied criteria like looking for objectively measured heights and weights by staff and individuals like staff in schools who were trained to take those measurements. And we also sought sites where those reported declines could be confirmed as statistically significant. So in some cases, our staff received data from the site so that we could do those tests to confirm that the site had, indeed attained a statistically significant reduction. You see the baseline was 2004, and we sought follow-up data taken during or after 2009, and that led to a minimum of 2 data collections, and we sought additional data points if that was possible. So we started, as I mentioned, with that careful site selection process, and then once the sites were selected, we engaged in a number of different methods. We review documents to try to identify what we could learn about the various kinds of strategies that were implemented. We administered a survey we called an inventory of strategies, where knowledgeable representatives in each of the sites could talk about whether a host of different recommended strategies, things that we know are recommended in the literature, were implemented in those sites. And then we conducted site visits to interview representatives across a range of settings, early care and education, in community organizations, in schools, in healthcare, to find out more about what was implemented, who was involved in that, and how those things were implemented, and what kinds of barriers and facilitators were experienced. And then finally, our team also conducted a policy and contextual scan so that we were able to identify relevant federal and state policies, as well as learn about things like demographic characteristics in the sites. So after all of that, 4 sites were responsive and met all of these criteria: Anchorage, Alaska, Granville, North Carolina, Philadelphia, and New York City. And of those, 2, Philadelphia and New York City, are the ones I'll talk about today, because they were able to actually identify reductions in the rates of childhood obesity among minority populations. Specifically, in New York City, statistically significant declines in obesity were noted among students in grades K through 8. This occurred between the 2006-2007 and 2010-2011 school years, and the prevalence of obesity there fell from 21.9% to 20.7%, just over a 1% actual or real decline, and a 5.5% relative decline. And so interesting for our purposes today, obesity decreased significantly among children in all age groups and all socioeconomic and racial ethnic populations. However, in New York, the decrease was smaller among African American and Hispanic Latino children than among Asian, Pacific Islander, and white children. In Philadelphia, the statistically significant declines were identified for children in grades K through 8 as well, between the 2006-2007 and 2009-2010 school years. And obesity declined there from 21.5% to 20.5%, so again, about a 1% real decline. Here, the declines were significant for Hispanic Latino girls, and for boys who were African American, white, and Asian. Here in Philadelphia, the decrease was greater for African American boys and Hispanic Latino girls, so that led to a decline in disparities. And Philadelphia was the only site that attained a reduction in obesity disparities for children from these higher risk groups. Okay, so I'd like to share just a little bit about some of the types of strategies we learned about that were implemented in these sites. Let me just start by saying I can only share a little bit in the amount of time we have available. Many strategies were implemented in these sites. I'm going to talk just about a few that were implemented that were targeted specifically at children in the groups that actually experienced declines. So let's start with New York City. One example of a strategy implemented in New York that directly targeted children that in the age range that experienced the declines was improving nutrition standards for meals in all New York City public schools. So between 2004 and 2011, the city reformulated many of its menu items, and they emphasized reducing calories, fats, and cholesterol. And you can see here several of the specific activities that were implemented as part of that work. And this might be an example of a strategy directed at all students in New York City public schools. Okay, and another example, they launched a physical activity program called Move to Improve. This program helped teachers integrate fitness breaks into the school day, and the activity helped count toward a 120-minute PE requirement that they had for each week. and was designed to work in smaller classroom spaces, as you can expect to find throughout New York City. Okay, another thing that we sought really to try to understand across each of the sites was more about strategies designed to address health disparities. So the New York City Department of Health and Mental Hygiene has, as part of its infrastructure, 3 district public health offices. These are sited within communities that have higher proportions of low income and minority residents that experience health disparities. So addressing health disparities is a key kind of core focus for the Department of Public Health and Mental Hygiene. But the efforts of the district public health offices might have been directed more at adults than at children during that period of time. Okay, so let's take a look really quickly at a few of the strategies implemented in Philadelphia. One main initiative that was described by respondents is called the Universal Feeding Program. So this is a program that was authorized by the USDA. It uses a socioeconomic study to determine the percentage of students in each school that are eligible for free or reduced price meals. The school district then is able to set a percentage, and if a school in that district exceeds that percentage of students that qualify for free or reduced price lunch, then all the students in the school are eligible to receive this universal service or free school meals. Okay, so this program began as a pilot back in 1991, and Philadelphia at that time was the only city in the country that, or the only school district rather in the country that was implementing this approach. And then in 2006, an updated socioeconomic study was done, and Philadelphia designated about 200 schools, or 2/3 of the public schools in the city, as eligible for being universal feeding sites. This is a strategy you might look at and note was directed specifically at low-income students. In another example, directed at low-income students was the Eat Right Now nutrition education program. It's implemented for students in grades K through 12. It's provided specifically in schools where 50% or more of the students are eligible for free or reduced price meals. And you can also see here that nutrition education reaches about 90% of students in schools eligible for SNAP Ed funding. And then finally, I'll just note another strategy here in Philadelphia, this comprehensive district-wide school wellness policy. So the National WIC Reauthorization Act of 2004 called for all local education agencies participating in the National School Lunch Program to or other child nutrition programs to create local school wellness policies. And the Philadelphia policy included a ban on sugary drinks, as well as a policy around snacks. And you can see here the many areas that the guidelines covered, including nutrition and physical activity areas. And this might be an example of a more universal strategy that targeted students, again, across public schools in the city. So when it comes to addressing health disparities in Philadelphia, one of the things that we realized was that many of the initiatives implemented in Philadelphia by design would reach individuals experiencing health disparities. So for example, the Universal Feeding Program and the Eat Right Now nutrition education program were specifically designed to reach students in low-income areas. And one of the things that we heard from respondents was that the Universal Feeding Program in particular helped to bring more low-income students under the tent of the school food program, so that then when school nutrition policies were improved later, it had a greater impact or was able to reach more of those students. So Really briefly, many similarities that we noted in strategies across these sites. Again, I can't stress enough, there were a large number of efforts, various efforts underway in these different cities, many addressing nutrition in community and school settings. Also, we learned that many of the sites were early adopters of nutrition policies, like the kinds of things that were later mandated in the Healthy Hunger Free Kids Act. We also learned of that elected officials were generally very supportive of the nutrition and physical activity efforts underway in these cities. And then finally, interestingly, community-wide efforts. So things like an attempt at a soda tax or some kinds of mayoral initiatives. Even when those things weren't successful, respondents talked about how they helped to raise awareness across a broad swath of the community about the importance of healthy eating and activity. And so finally, as shared here, the sites that had reduced childhood obesity rates in minority and low-income communities seem to have some focused effort at reaching those groups specifically. Okay, so I'll just wrap up sharing a few limitations. Of course, as mentioned, this was an exploratory case study. That's the first limitation. You know, we weren't able to assess causality associated with like specific initiatives. We also had a small sample, right? A small sample of cases, a small number of respondents ultimately that we were able to talk with, and really could only explore in detail a limited number of the broad range of strategies I mentioned that we learned about. And then of course, because it's a retrospective design, there's always a risk of some memory bias as well. But our work really sought to learn more about the types of strategies that were implemented in these communities and how. And very detailed reports on each of the 4 sites are now available at the link you see there on the NCORE website. I hope that you guys will take the time to learn more about them, because again, I was only able to share really a minuscule fraction of the many things that took place in those sites. And it's really interesting, very interesting information. Okay, well, thank you all. There's my contact information. And I guess I'll turn it over for questions.
Great. I think we have time just for 1 or 2 questions because we want time for the discussant. Go ahead.
Right. Okay, go ahead. Oh, okay, sorry. Go ahead.
I just want to ask, you showed gender differences for Philadelphia, but
Yes.
you didn't for New York. Were there gender differences?
Oh, okay, that's a great question. So in New York, the data did not look at the gender differences, but did look at socioeconomic and age group. Right. Thank you. Good question.
Hi, that was a great
I don't think that's on.
That was a great presentation. Thank you.
Thank you.
I just wanted to note that in the New York experience, why we didn't see changes in disparities, or actually we saw greater changes in white and higher income children.
Right.
In school age, the analysis of the preschool work was quite different, and Jackson Sakobo published that. And we found that after the 2007 regulations of the daycare environment and a number of interventions in the early childhood sphere, there were reductions in disparities in Manhattan and the Bronx, but not Brooklyn.
That's that's so great, really very positive outcome, yes, and great to hear. And you're right that I didn't limited time, but didn't get to talk about the daycare regulations and that work that occurred for younger children as well. There's a lot more complexity, I guess, to the point that Shariki was making earlier in all of this around the particular subgroups and the intersection of that with gender and age as well. Thank you.
Great. Thank
All
you
right.
so much. Okay. And now our discussant, Karabi, if you'll come to them.
So good morning, everyone. Thanks for 3 fabulous presentations. as a discussant, I'm going to take the liberty of not trying to summarize or comment on 3 amazing presentations, but rather just tell you a little bit about why, and talk a little bit about why we should learn internationally. So I'm Karobi Acharya. I'm pretty new to this group. I'm at the Robert Wood Johnson Foundation and leading a new portfolio of work at the foundation called Global Ideas for U.S. Solutions. And the idea with that work is really to learn from abroad. And so I wanted to talk just a couple minutes about why learning from other countries is so critical to this work and why RWJF is investing in global learning. So there are many reasons not to learn from other countries. Other countries have very different social, political, economic, healthcare environments. The norms and values are different. How can we possibly expect to find ideas that are relevant and feasible to the U.S. context? It's logistically difficult, as we experience with Tim. Sometimes connections don't work. Sometimes we have to work across languages through translators or travel far, take early morning calls. And yet, on the face of it, I think most of us would agree that it's always good to learn what other places are doing. And I wanted to just offer up, I guess, 3 very specific reasons for why we should be learning from other countries. So the first is, it's sort of a cliche that we live in this globally interconnected world. But this is especially true for food systems. These food systems include retailers, food manufacturers, global agribusiness, and in addition, of course, social and cultural norms spread rapidly through our global environment, through entertainment, through food chains, and of course international migrations, as has been mentioned. So it's critical that we understand the larger context and the global forces at work that shape both the nutritional quality of the foods that we eat and the norms that guide how we eat. We just can't really think about making changes without understanding those very real global forces. The second reason I'd offer up is, of course, we've heard from Tim, and we all know the obesity epidemic is global. Many countries are trying lots of approaches to tackle it, and these provide fabulous opportunities for sort of natural experiments. So, for example, when Mexico introduced a tax on sugar-sweetened beverages, we were able to support an evaluation of its impact that's going to inform policy discussions around the United States. And in addition, we often find programmatic interventions that can be adopted to the U.S. There's another session here at this meeting that's going to focus on the experience of open streets and ciclovia. This approach started in Bogota, Colombia, where they closed off over 100 miles of streets every single Sunday for people to exercise, to do classes, to go biking, etc. Cities here in the U.S. often said, well, we already do that. We close streets down for a year, maybe twice a year. But what's critical to the Open Streets program is the number of miles, the extent of the closures, and the fact that it is every single week. It is the dose and duration, if you like, of the program. So there are lots of great ideas that are happening in other countries that we can think about bringing to the U.S. And the third reason for learning from abroad is really inspiration. So at RWJF, we have a vision to build a culture of health that's really about building a social movement towards a culture of health. And we know that any social movement requires a vision of the alternative future. What does a culture of health really look like in schools, in communities, in workplaces? So by examining how other countries are reducing obesity, we can develop a sense for what might be possible. And just to give you an example of that, we've supported a group called MEDIC, which brings American healthcare professionals to Cuba on study tours to understand the Cuban system. Now, those folks are not looking to bring the entire Cuban system to the US, of course, it's very different. But they've been inspired by the cross-sectoral collaboration between the health department, Parks and Rec, and transportation to coordinate daily exercise for its citizens, as an example. And they're bringing those ideas back to the underserved communities where they work. So often places that are achieving outcomes in low resource settings can have implications for low resource settings here in the United States. So I just want to emphasize that I think it's really important that we do look abroad. We have a tendency to feel that we're a bit of an island here in the United States, despite that we are attached to a couple other countries. And I would be remiss if I did not put a plug in for this. This is on your chairs. This page that says "What If" is just a quick synopsis of the work of our portfolio, but importantly on the back is an open call for applications that we have open now. It's a funding opportunity for learning from abroad, and I hope that you will look at it and pass it on to others. Thank you.
Well, I think we've come to the close of the hour. This has been a great set of discussions and presentations, and it's really just a snapshot of some of the activities that are going forward. So I think we have to close, given that people are probably also trying to move on to other sessions. So thanks, everyone. It's great to see so many people here on such an early morning session, and I hope you will take the opportunity to go to some of the other in-course sessions that are later during this meeting. Thanks.